So a couple of years ago, they reported the follow-up study. So out of 32 patients who were listed for liver transplant, 18 patients underwent liver transplant. The median number of tumors were 2, and median cumulative diameter was 10.4 centimeter in the imaging study. So 1, 3, and 5-year overall survival rates were 100%, 71%, and 57% respectively. So this study shows the comparison between the transplanted group and listed but not transplanted group. Transplanted group showed a little younger compared to the not transplanted group, but sex, ethnic, pre-existing liver disease, CA99 level, and radiologic, pathologic tumor features were not different from each group. These are pathologic features of the liver transplant group. About 61% of the patients showed stage 2 tumors. So most tumors were moderately and poorly differentiated. Pathologic tumor numbers were 2, and the cumulative tumor diameters was 8.5 centimeter, ranged from 2.9 centimeter to 20 centimeter. 33% of the patients had lymphovascular invasion, and 27.8% of the patients had perineural invasion. 72% of the patients received adjuvant chemotherapy after liver transplantation. So these are the survival curves. The upper one showed the patient survival rate, which shows transplanted group had 71% of 3-year survival rate, while not transplanted group showed worse outcome. The lower one is recurrence-free survival rate of transplanted group, so which shows 52% recurrence rate in 3 years. Thus, selection matters. If we select the early stage intrahepatic cholangiocarcinoma or responder from neoadjuvant chemotherapy, so we could get somehow better outcome. So let me summarize the current consensus about liver transplantation for intrahepatic cholangiocarcinoma. So this is a report of ILTS consensus meeting that discussed the liver transplantation for intrahepatic cholangiocarcinoma and mixed HCC and CCC. So in this conference, they suggest liver transplantation for intrahepatic cholangiocarcinoma like this. So in case of a very early intrahepatic cholangiocarcinoma like a single tumor less than 2 centimeters, upfront liver transplant may have benefit, and unresectable advanced intrahepatic cholangiocarcinoma may become liver transplant candidate if the disease remains stable after neoadjuvant chemo. So this is a moderate level of evidence and conditional recommendation. So when liver transplantation is planned for a cirrhotic patient with a nodule demonstrating atypical radiological features, tumor biopsy is strongly recommended, and genomic profiling could be suggested for future studies. So with a high level of evidence, the treatment of choice of intrahepatic cholangiocarcinoma is still liver resection. But liver transplant is reserved for unresectable cases and should only be performed under very strict clinical protocols or trials with moderate level of evidence. So in 2021, the Spanish Society of Liver Transplantation reported consensus statement and recommendations for expanding indications of liver transplantation. So in this report, about treatment of intrahepatic cholangiocarcinoma in patients with liver cirrhosis. So in selected patients with portal hypertension and intrahepatic cholangiocarcinoma, liver transplant could be considered only in the context of well-designed randomized trials, which is recommendation level 2B. The diameter of the tumor is tightly associated with post-liver transplant recurrence. Thus, only single nodule tumors less than 2 centimeters without vascular invasion would be acceptable, which is level 1B. So management of a patient within the waiting list concerning prioritization and surveillance should mirror established protocol for hepatocellular carcinoma, which is level 2C. Tumor progression like increase of diameter beyond 2 centimeters, new nodules, vascular invasion, and significant of CA99 levels, or extrahepatic spread should motivate exclusion from the waiting list. And retransplantation is contraindicated in patients with tumor recurrence. So Maspero published a review article about liver resection and transplantation for intrahepatic cholangiocarcinoma. In this review article, the liver transplantation can be considered in case of a very early stage, unresectable intrahepatic cholangiocarcinoma without lymph node metastasis or distant metastasis. In addition, the careful approach is needed for locally advanced intrahepatic cholangiocarcinoma with neoadjuvant chemotherapy. So in this article, the outcomes of liver transplantation for intrahepatic cholangiocarcinoma patients were summarized in this table. So on behalf of multiple studies, the Toronto group showed very good outcomes in 15 cases of single tumor less than 2 centimeters, so which shows a 65% of 5-year survival rate. And MD Anderson reported the result of a prospective study showing good outcomes of advanced intrahepatic cholangiocarcinoma with neoadjuvant chemotherapy, which showed 83.3% of 5-year survival and 50% of 5-year disease-free survival rate. So Machapero summarized the indication and eligibility criteria for liver resection and transplantation like this. So I'm going to show a little simplified. So younger than 65 years and no comorbidity contraindicating liver transplant. So unresectable tumor less than 2 centimeters and very early tumors arising in chronic liver disease. But if the tumor is larger than 2 centimeters, so we can watch the chemo and radiation response before deciding on liver transplantation. Absolutely, there should be no macrovascular invasion and no nodal metastasis. In terms of donor, so they propose to use DCD and marginal graft or living donor. So in Korea, so we don't have much experience performing liver transplant for intrahepatic cholangiocarcinoma intentionally, but most centers experienced mixed hepatocellular carcinoma and cholangiocarcinoma. So it is a little bit different story from intrahepatic cholangiocarcinoma, but we could get some